Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. I'm your host, Ross Orbit. I'm a practicing emergency physician in Southwest Colorado, and I'm joined, as always, by my co-host, Will Berry, who's a crit care flight paramedic in North Carolina. Will, how you doing?
Good, Ross. Good to be back with you, man. I'm excited for this episode.
I am too. So we have back with us today, no stranger to the show, Nik Matsler. Dr. Nik Matsler is a toxicologist, a fellowship-trained toxicologist who's now currently practicing in Oregon. How you doing tonight, Nik?
I'm doing very well, Ross. Thank you guys so much for having me on the show again. I'm glad you guys aren't completely sick of me at this point, as I love being here and having the chance to talk to you guys.
Oh man,
No, you always
good to
blow
have you
my
on the show.
brain wide open, Nick.
Yeah, absolutely. So one of the impetuses to this show was I was working a shift a while back, maybe last year, and I had this mom who brought this kid in who dad was out in the yard mowing the lawn, and kid was out there. Next thing he knew, kid was chomping down on a mushroom in the yard. And so parents called the poison center. Poison center told them to bring them to the emergency department. And I'm on shift, and I text Nick, and I'm like, this sounds like bullshit. The kid just ate a mushroom in the yard. And Nick was like, no, you got to worry about this, dude. And so I wanted to talk about, okay, this is something we don't always think about we need to worry about. But what's up with mushrooms, Nick? Why do we got to worry about these?
Yeah, that's a great question. So, that is a perfect example of one of the most common presentations that we're going to see for mushrooms. I would say sort of the most common thing is, a kiddo in the backyard or out on the hike with the parents, and they accidentally get into a mushroom that they find sitting there, either in the yard or on the side of the trail. That's probably one of the most common. And then, of course, the next most common is all the intrepid foragers out there that go out looking for mushrooms, and they're picking a bunch, and they don't always quite know 100% what it is, or maybe they feel confident they know what it is, and then maybe they develop symptoms later, so they come into the emergency department. So the problem is that we're going to see a lot of these in general, and they're going to have an incredibly diverse set of presentations, and it's very, very challenging to know up front whether it's a mushroom that you really need to worry about or whether it's a mushroom that somebody is going to be just fine. And so for exactly that reason, this is very useful to talk about and just make sure people understand sort of the varied presentations that come along with these.
And you were telling me even for fellowship trained mycologists, it can be difficult to specifically identify the mushroom.
Yeah, mycologists have like a superpower. They are like incredible. They will look at these mushrooms and they'll just be like, I know 100% what this is. But then sometimes even for these folks, they will look at a mushroom that to my eye looks almost identical to the one they just identified. And they'll say, gosh, I'm not 100% confident whether it belongs to species X or species Y. And that's, again, what makes it so challenging is sometimes they can be very straightforward in terms of identification. And then sometimes you can have two mushrooms that even to me look almost identical, and yet they're two completely separate species that are going to have two completely separate disease profiles attached to them.
I got to be that guy in the room. What is a mycologist?
That's right. That's a great question. Myco is the combining form for fungus, and ologist is obviously to study. And so mycologist is somebody who studies fungus for a profession. And so we are very fortunate to have lovely academic colleagues. Usually we find them in the local universities, in the state schools and things like that. But we are lucky to find mycologists who are willing to be affiliated with our poison centers here in the U.S., and they often work very long and thankless hours and get woken up at 3 a.m. to talk about finding a mushroom, and they don't get paid anything for this, but they are gracious enough to lend their support and help us identify mushrooms when we send them pictures or physically send them samples. And so they are a very important part of our toxicology ecosystem, and I very much love our mycologists for doing what they do.
And so it sounds like every poison center has one of these on call. So if you're out in the field and you're dealing with one of these, you can call your local poison center and get some help.
That's right. Most poison centers, to my knowledge, have a mycologist on staff, or they have a pathway to get to a mycologist if they need to. And so, even for example, a poison center, if they did not have one that they could access, they could reach out to a sister poison center and ask them for help with one of their mycologists. So we have ways that pretty much no matter what, if you can get a cell signal, we can probably get to a mycologist with some degree of separation who is going to be able to help us identify a mushroom.
I've run over mushrooms with my lawnmower, and then I know there are people too that buy mushrooms to trip. So there's a lot of shades of gray in there. Can you help me understand this whole, there's a lot of different types, and some do things that people desire, some are benign. What is it about mushrooms that makes them what they are, and how broad is the spectrum of mushrooms?
Yeah, that's a fantastic question. Mushrooms have just an incredibly diverse range of chemicals within them. And so there's all sorts of xenobiotics, these different kinds of proteins and enzymes that live within these mushrooms, that can be created in these mushrooms. And depending on exactly what the substance is, it'll produce various effects in people. Now, most of the mushrooms out there are going to produce effects that we don't like. So things like nausea and vomiting, things like cough, things like almost like a muscarinic-like toxicity, things like acute liver failure that can be fatal. So there are a lot of things that people don't like from these mushrooms. And then every now and again, there's one mushroom in particular that tends to have people come back over and over again to try them, and that's mushrooms that are psilocybin containing. So in my brain, I sort of lump them into two general categories. It's sort of the psilocybin containing mushrooms that have their own considerations, and then there's sort of everything else and all the other mushrooms out there that just have an enormous degree of variation. And it comes down to each mushroom producing a different chemical inside of them. And that specific chemical tends to produce different effects. So depending on exactly the kind of mushroom we're talking about, we're going to see this huge variety of presentation.
And to be clear, the psilocybin mushrooms you're talking about, those are the hallucinogenic ones.
Yes, thank you, Ross. Yes, psilocybin-containing mushrooms, those are the ones that we colloquially talk about as magic mushrooms. And again, there's lots of different species of these actually that produce psilocybin and produce psilocybin in different concentrations. And so, just because one mushroom might look a certain way and you associate that as a magic mushroom, you might have a different species that looks a little bit different and still contains predominantly psilocybin in different concentration. But psilocybin is the active ingredient that we think about when we talk about magic mushrooms in general, and they are the hallucinogenic kind. And so there's those specific kinds of mushrooms, which again will have a lot of different names and come from different species in general. But overall, they're like one branch that will give you like hallucinations and some of these euphoric effects that people seek out. And there's sort of all the other species that are going to do different things.
Nick, question. As a toxicologist practicing in and around an emergency department, what are some different ways that people encounter these mushrooms other than ingesting them on purpose with those desired effects in mind?
The number one way that people are going to get these is, as often I would say, just foraging mushrooms. So there's still people that are eating them, but they're eating them more for like the desired flavor and taste, and they're trying to like spice up their cooking. So a lot of people will go out, especially during the wetter months when it's kind of warm and wet, which is like the favorite environment for a fungus to grow. So you'll see these people, especially like in the springtime, will go out for foraging mushrooms, find these like beautiful growths and gatherings of mushrooms out in the forest, and they will try to identify them themselves, and then they will pick them and then oftentimes bring them back to their house and then just cook them or eat them raw. And part of the problem with this practice is that a lot of the toxins contained within these mushrooms are often heat stable, meaning that if you try to boil these things or add them to like the rest of the cooking in the frying pan or anything else like that, you're not going to inactivate that toxic component. And so it might taste good, but at the end of the day, you may develop some pretty significant symptoms depending on exactly which one you got. And so some people are going to go out foraging for these things and find them and intentionally eat them as part of a like overall like menu item. Some people like the kiddo example that we talked about are going to go into the backyard and they're going to find whatever they can get their hands on to eat, like mushrooms that are just hanging out. And then there's going to get people that either try to seek out magic mushrooms. Oftentimes, they will grow in cow pastures. And so people will go out looking for magic mushrooms out there. Or there's these kits that you can buy online and order them and try to grow these magic mushrooms yourself. So oftentimes, people that are pursuing the more hallucinogenic compounds, they are looking in very specific areas or ordering very specific kits. And I have to admit, I at least personally in my practice, I don't see a lot of overlap between the two groups in terms of like the people that are foraging and the people that are using the hallucinogenic mushrooms from like their home grow kits and things like that.
Yeah. So are there many case reports about like somebody who was trying to buy magic mushrooms or hallucinogenic mushrooms and accidentally got one of these toxic mushrooms instead?
There's not a ton, to tell you the truth. There's certainly like have been some suggestions that this has happened in the past, but it's not a common way that this is found. I would say the people that really tend to get themselves into trouble are the folks that are foraging for the mushrooms and then accidentally misidentify a mushroom and ingest it from that capacity. However, there's always fear that that could happen to somebody who's seeking out like a hallucinogenic mushroom if they don't get it from like a reputable source. There's also too like people that have just been eating in restaurants, for example, and the chef has prepared a meal with a mushroom that they've gotten from a company. There's been some case reports of people having toxicity, and at the end of the day, when they try to drill down and trace back to what the dishes had in common for the people that got sick on that particular day at that particular restaurant, what they find as a common ingredient is maybe one bag of mushrooms that came from somewhere. Oftentimes, these people aren't getting like liver failure in the more extreme examples of mushroom toxicity, but people are getting hospitalized with severe nausea, vomiting, diarrhea from it, and begs the question whether some of these could have been misidentified mushrooms or whether this could have been foodborne illness that came from a different overlap. It's always tricky to know, but you do find these oddball case reports of a suspected mushroom toxicity without like the classic vector of, oh, I went out foraging on my own and maybe I accidentally wasn't getting what I thought I was.
So Nick, okay, you're breaking this down: psilocybin-containing mushrooms and non-psilocybin-containing mushrooms. So let's set the psilocybin-containing ones aside for a second. So me, I'm a paramedic. I'm in the field. I have a case in front of me. A patient ingests some mushrooms. It takes someone with a lot of training to even identify these things. What symptoms am I looking for in this patient to let me know that this is something I need to be concerned about or may have to react to right away?
In general, one of the kind of old adages when dealing with mushrooms and mushroom toxicity is the sooner you get symptoms compared to your ingestion, actually the little less worried we are about you. So if you eat a mushroom from your backyard or from foraging and you start throwing up within a couple hours, actually automatically I am now a lot less worried about you than if you come in and you say, you know what, yesterday I ate a mushroom and gosh, maybe 12 hours later I really started vomiting, having diarrhea, and I came into the emergency department. You know what, I'm a little bit better right now. But those later presenting symptoms are much more concerning because they're typically indicative of a more serious toxin. When I think about the mushrooms that are not the hallucinogenic mushrooms, I think about a bunch of different categories. I think about mushrooms that are really scary, dangerous, and those are the ones that contain what we call amatoxins or cyclopeptide or phallotoxins. These are all things that we find in a whole host of species of mushrooms. And these are the ones that we classically think of as the toxins that are going to harm your liver and that are going to lead to fulminant liver failure within a few days after you eat these mushrooms. And unfortunately, we've seen outbreaks of these. Like there was an outbreak in Oregon years back where several individuals all ate the same mushroom patch thinking that it was an edible mushroom and all had the same dish and then all required liver transplants within the week, unfortunately. So there's these like really scary, dangerous ones. And those are ones that typically don't have symptoms until well after 8 hours after you ingest them. Whereas one of the more common ones that people ingest is something that we colloquially refer to as little brown mushrooms or LBMs. And these are exactly what they sound like. They're many different species of these little tiny brown mushrooms that people often mistake for edible ones, and they go home and eat them, and within a couple hours they just start throwing up their life, and they come into the emergency department. And with those patients, I often say, great, let's treat them with Zofran, let's get their nausea better, and then we talk about some follow-up plan from there.
And so break down what these toxins are and what they do to our body and why that's so concerning.
Absolutely. To talk about some of the ones that are sort of less concerning, and saving sort of the liver toxic ones for last, we see toxins that do all sorts of things. So one of my one of the ones I find personally the most interesting is one called gyrometrin, which is has a metabolite that we call monomethylhydrazine. Now, the only reason I bring up monomethylhydrazine is because hydrazine in general is something that you will see in different forms. It's in certain TB medications. It's in jet fuel, believe it or not. And these hydrazines will cause a process to happen in your body that will eventually lead to seizures. And these seizures are really interesting because it's really hard to stop them with benzodiazepines alone. And we have to actually give this special vitamin, pyridoxine, to actually try to stop these seizures. So you can actually see these like very interesting toxins that are in there. So there's these weird and wonderful ones that are in there, but then there's also, just ones that contain these GI irritants. There's ones that contain something called arelanine, which causes nausea, vomiting, and sometimes leads to liver or kidney failure. There's something called alenic-norleucine. It also has nausea, vomiting, leads to a little bit of kidney failure. There's one that can cause rhabdomyolysis in patients. There's one that can cause hemolytic anemia. There's even mushrooms that have spores that if you agitate them, they'll puff and release all these spores into the environment. And if you breathe a lot of these spores in, you can end up with a pretty wicked cough and some pulmonary irritation that sometimes leads to you needing to be hospitalized for supplemental oxygen therapy. So you can really see a huge diversity, not only in appearance of these mushrooms, but in the toxins you find contained within.
And so you said one of these toxins can cause seizures. If we see somebody with a reported ingestion of mushrooms who has seizures, what are we going to do on the ambulance for this?
Yeah, that's a great question. What I would do is the good news is I would treat them supportively just like you would any other seizure. But my suspicion as you were driving to the hospital and you started giving more and more benzos would get higher and higher if the benzos really aren't working. Because what we know with these style of seizures is they often don't respond to benzos alone. And so, if you're like, wow, I've given this person 5, 10, 15, 20 milligrams of midazolam or Versed, and it's still not working. They're still seizing back here. And especially if you had the story of a mushroom ingestion prior to this, it would start building a case that we're dealing with something else. And again, I think almost every time I've been on the show, one of the things I harp on is that one of the most amazing things that EMS often does is they often pretty much get the diagnosis for me because they really set us up for success, because they say, here was the clinical scenario that I found this patient in. And that helps us on the other end of the ball really drill down and get a higher or lower suspicion. Like if you brought in a seizing patient and never mentioned anything about the mushrooms, I think it would take me quite a while to work through the differential before I got down to the point where I'd say, shoot, maybe I should try some pyridoxine to see if it's going to work in this patient that continues to seize. Whereas if you walk in the emergency department and you say, yeah, family says that he went foraging for mushrooms and made a big dinner of them several hours ago and then was found seizing on the floor. Well, now that changes things so much for me that I could get to the right answer very quickly. And so I think that's one of the difficult things about pre-hospital medicine, but also one of the really brilliant opportunities is to figure out these kinds of interesting puzzles. And so when you hear a story about the ingestion of mushrooms, don't immediately throw that one away from your brain. Keep that in the back of your mind just in case it might be an important detail for us on the other side.
Yeah, great. And so you talked about these mushrooms that mainly will just cause nausea, vomiting, diarrhea. Some may lead to renal failure, or maybe some rhabdo, maybe some anemia, or these refractory seizures you just talked about. You teased us with the liver toxin ones. What's so scary about these ones?
Yeah, I think the liver toxic ones, I think, are the most classic mushroom ingestion for me. I feel like when I was, not even in EMT or paramedic school, I feel like when I was just in college, and maybe it was anatomy and physiology or somewhere. At some point we covered mushrooms and it was like, oh yep, they're going to kill your liver. And I feel like throughout my entire life, the one thing that I knew about poisonous mushrooms was they were going to like harm your liver. And so I think when I got into toxicology and I found out all these other weird and wonderful things that mushrooms can do, I think it kind of blew my mind a little bit. And so the liver tox is still kind of the classical paradigm for me. And these toxins are very tricky because the problem is that, whenever you ingest something, and when we talk about medications, especially, you guys are all familiar with it. And we talk about like first pass metabolism. And of course, like first pass metabolism is like, well, if I'm absorbing a drug from my gut instead of through an IV, well, it's going to go through the portal system and it's going to go to my liver first. And my liver is going to have at whatever that substance is. And then before the rest of my bloodstream sees it. Well, the problem with these toxins is they want to go to the liver. They want to go there to do their work. And so the problem is you eat them, it goes through the portal system, and the liver has first crack at it. And when they absorb these toxins, sort of once it gets into the hepatocyte, that's sort of game over for that particular cell. So these toxins, when they get in there, they bind to one of the RNA polymerases in the cell. And essentially what that means is that the cell can no longer do DNA transcription, meaning that it can no longer produce proteins to continue functioning as a cell. And so that cell is going to die at that point. There's no way to salvage it at that point. And so once the toxin gets into the cell, it's sort of too late to do anything for that particular cell. So all the treatments we use are just aimed at trying to sort of prevent that uptake of the toxin in the cell. And so what I find so scary about these is that you can eat these mushrooms and oftentimes you'll feel nothing for like the first 6, 7, 8 hours. You'll feel probably pretty normal. And unfortunately, I'm told that from people who have had these mushrooms on accident, these mushrooms actually taste really good. And so one of the problems is you might have the entire dinner and say, gosh, like that was a pretty good mushroom dish, like fantastic, high fives all around. Then, 6, 7, 8 hours later, you get some nausea, vomiting, you're not quite sure what's going on. And then you start improving from that again. There becomes this other phase that we call the quiescent phase where those symptoms start to resolve and you think, oh, okay, I must have just had a bit of foodborne illness or something like that. And then 36, 48 hours later, all of a sudden you start showing some classic signs of liver failure. And if you haven't presented to care before this, you're definitely coming to the hospital now. And now you're in fulminant liver failure. And unfortunately, almost the only thing to do at that point is to try to support your body and list you for transplant.
Jeez, that's kind of scary, actually. Nick, as I hear you talk and I think about poisonous things in general, I can't help but think about snakes. And how, I live in North Carolina and we don't have king cobras here. And I keep thinking about that in relation to these mushrooms. Like, are there certain regions globally where like there's higher concentration? Like, if you work in Oregon, if someone came in and was like, I think they're in liver failure because they ate a bunch of mushrooms, would you be like, no way, we don't have those here? Or is it anything like that?
So actually, I think that's a really important point you bring up. And we do see a great deal of geographic diversity in terms of these different kind of mushrooms. The bummer is that the mushrooms that contain the enzymes that hurt your liver, these cyclopeptide containing compounds, these amatoxins, these phallotoxins, all of these toxins are unfortunately found in species that are pretty much found throughout the continental US, excluding parts of Alaska. And then there's always the concern about importing. And I would have less concern if this came through conventional means. Really what I mean is like, if somebody went foraging in a different state and then brought a jar of mushrooms or brought a dish cooked with mushrooms to a different state, that would be another possibility. But you're exactly right. There is some diversity in terms of how it's broken down by region. When you call your local poison center, they will have an idea of the mushrooms that they commonly see there, and they'll be aware of the geographical differences. And so they'll be able to steer you away from one flavor of mushroom and point you more towards a different flavor of mushroom, just depending on where you're calling from. And I think I really like your analogy to the snakes too, because I think when I was here on the snake podcast, I begged people to never bring in the snake because we don't need it. It doesn't matter. Like, we can treat a snake bite in the continental US without ever seeing that critter. You please leave it alone. But for the mushroom, dear Lord, please bring it in. Bring it with you, because then our mycologists can go to work on it. And even like, somebody that's been throwing up into one of your emesis basins, like, bring that on too, because we want to see them chunks, because like maybe that has the mushroom in it that we can identify, or when I say we, are intrepid mycologists. But hopefully we can figure out what it is.
Wow.
Yeah, so what I'm hearing you
vomit.
say, yeah, bring the vomit, and then keep a high, as an EMS provider, keep a high index of suspicion, because these incredibly toxic mushrooms are found all over North America potentially.
Yeah. So Nick, how as EMS providers can we identify this pre-hospitally? Like, what clues us in, and then how can we then help the emergency department identify what's going on so that we can quickly recognize and appropriately treat it?
Yeah, first I want to say, I think bring the vomit might need to be made into a t-shirt at this point. But no, I think you ask a really important question. I think this is one of the ones where I would not, when I listen for hoofbeats, I wouldn't think zebras in this case. I would go into these encounters thinking normal things. I wouldn't walk in on a guy who has, empty Jim Beam bottles everywhere and who is seizing on the floor. I wouldn't immediately go, you know what? That's mushroom, like 100%. Like, I would go into your encounters still, thinking about common things being common. But I think you guys have an opportunity to see somebody's home environment often, or at least where they're being brought in from. And there's so many environmental clues that you might pick up on when you're in that house. And you might hear little bits of information from family members that's in the background that's sort of irrelevant at one time while you're talking to the patient. But I think exactly like you said, somewhere in the back of your mind, think about what people are eating, because today we're talking about mushrooms. There's all sorts of other kinds of toxic plants out there. And so when you're thinking about these kinds of things, like, I don't always consider what somebody does for their job in the emergency department, but sometimes when I'm talking to them, I'll hear weird stories, and all of a sudden I'm like, you know what do you do for work? Because maybe I'll catch some oddball things when it starts popping into my head. And so I think that's the same thing. Like, when you guys have environmental cues that fill you in on, like, hey, they just cooked dinner, or hey, there's a big table full of mushrooms from them foraging in bags that they brought home, or any of these other kinds of context clues, perk up to them a little bit and start asking your patient a few extra questions, because you might really make a hero play in the emergency department when you're like, oh, by the way, we also brought in these mushrooms in case this was the cause, because you might really put us on a path to actually get this patient help in the timely fashion that they need.
What are we going to do in the emergency department if we're like, oh, could possibly be a mushroom toxicity? How do we then approach that from the emergency department?
Yeah, it's an interesting way we approach it, because for the most part, we play the odds. And what I mean by that is, even though in most of these very scary ingestions, we say, gosh, if you have symptoms within the first few hours, you're safe. And if you have symptoms, beyond 7-8 hours, now I'm more worried about you. Even with that, unfortunately, there have been some suggestions or reports that even the liver killing mushrooms sometimes have early symptoms to come along with them. It's just a much more rare presentation of that, and some people take argument with it overall. But honestly, what we do is we try to get the mushroom identified. The best case scenario is we have the mushroom and we can have a mycologist positively identify it, because then we know exactly what's going to happen to that patient. We can predict what toxicities they might get in the future, and then we can create a follow-up plan. So some of the ones that cause renal failure, well, they don't cause renal failure for like a week to 10 days. And so you will get over the initial GI symptoms within the first few hours. And so we can treat you supportively. If you're so sick, you need IV fluids in the ER, need to be admitted for, fluids for 24 hours and antiemetics. Or we might get you to the point where you're eating and drinking and it wasn't so bad, and we discharge you home. And just in case it might have some of these kidney effects, we make sure that you have follow-up appointments, for 10, 14 days so you can get your creatinine rechecked to make sure nothing's wrong from that perspective. Or you might have, seizures that aren't stopping, and we'll give you pyridoxine to make sure we can head those off. Or you might end up with rhabdo and we'll treat you for that, or these kinds of various treatments. So if we can positively identify it, that's going to be a really important step. If we cannot positively identify it, I would say now here's a very large diversity of practice at different poison centers. But I would say for the most part, it comes down to sort of playing the odds, meaning that we say, okay, you had symptoms within the first couple hours. We don't think you're going to get real sick. We think that's a protective factor overall. We can't be 100% sure. And so we really ought to have your liver enzymes rechecked in, 48 hours or so. But we often discharge those people home. Whereas if you had symptoms right away and we really thought you got one of those dangerous mushrooms, we might admit you to the hospital and sort of do more wild treatments to try to make sure your liver doesn't fail you, or at least give you the best shot we think we can for that kind of an outcome.
What are those treatments to try to prevent that liver failure?
Yeah. So charcoal is still one of the number one things. I love it because it's good for almost every kind of intoxication that you can get. But charcoal still works. And so if we can get to somebody real early, and even because this is such a scary, dangerous one, and because it has something called enterohepatic recirculation, we give charcoal even late too. And we give it sometimes multiple times. And that's this whole phenomenon where, this toxin, it got absorbed from the gut through the portal system to the liver, and then it went from the liver into the bile tracts to your gallbladder and then back out into the gut and the bile, and then it just recirculates back up. It gets reabsorbed. And so it just does this whole circle in there over and over again. And so if we give you some charcoal, even several hours after your ingestion, the hope is that it starts to adsorb some of those toxins in that enterohepatic recirculation loop and then eliminate them from the body overall. And so charcoal is still going to be important in these cases. And then we have all sorts of weird and wonderful things we do where there's some antibiotics that we sometimes give to inhibit certain transporters in the liver so that we hopefully don't absorb as much of that toxin. And this is just a random side effect of antibiotics that we know about. There's also a substance called psilocybin that we think will help bind to the toxins itself. And then some people have even suggested all the way to things like biliary drains, where literally we're just going to drain the bile out of you percutaneously, trying to encourage as much of this toxin to leave your body. And it all sorts of depends on how soon you present into care and how confident we are in it being a very scary ingestion or a very minor ingestion. I would say for the most part, we are treating people symptomatically and we are risk stratifying you. And often I think it results in a discharge home within several hours if your symptoms have improved or resolved. And if we really think you're in that narrow category that got something really scary, dangerous, then I would almost universally suggest we admit them to the hospital.
Nick, regarding the seizures, on my helicopter, we carry Keppra. If I had somebody in front of me that was seizing and I felt like I wasn't able to stop it, I would start thinking about that. Are any of those other second line meds going to help, or do you have to have the one you mentioned?
I think that's a very important question, because when we talk about these seizures that don't stop until you give them vitamin B6 pyridoxine, when we talk about these kinds of seizures, we really do make it sound like, no, it's impossible for the seizure to stop until you give this medication, because that's how we want to teach it in medical school. We want to make sure that you're very afraid of it, so that way you think of it. And I think that's part of the way we do our didactic education overall. The reality is that patients are probably going to respond somewhat to usual therapy, meaning like you're probably going to get the seizure or respond somewhat to benzodiazepines. I'm not aware of any literature specifically looking at Keppra for these, but I would always just work through your algorithm for seizures. I think that's exactly the right approach, and say, okay, I'm going to give these. If you knew 100% that it was, this specific kind of ingestion, and you didn't carry the drug, I would still just keep working through it until you got the patient to that drug, and then I would absolutely give that to him immediately. But I would say if we're unconfident as to what it is, just treat it like you normally would. And people are probably going to respond fully or partially to these sorts of interventions. So don't give up on them 100%. But keep an open mind, because even me, when I start working through these things, even in people with seizure disorders, somewhere in the back of my head, as I'm like, wow, I've given a lot of medications to try to suppress these seizures and it's not going away, I start thinking, maybe I should look in their chart for TB meds. Maybe I should think about empirically giving some B6. And so it even crosses my mind in these cases, but especially if you have a high index of suspicion because of a good story, I would do the normal things until you can get them to the definitive drug and then immediately give it to them.
So, but to cap a little bit of what you're saying, identification is huge. We're not going to probably do it in the field. There's a lot of different types of mushrooms, a lot of different effects from them. There are whole people that devote their entire education and career to identifying these fungi, right? So bring it in. If you're a paramedic or an EMS provider and you can bring in anything, they'll try to work with it. So the emesis, remnants of what they ate, baggy or whatever, bring it in and let the professionals try to deal with it. Would you agree?
Absolutely. I think that's exactly it. It's like, maintain your index of suspicion because you're the one out in the environment that gets to bring them in, that gets to see it firsthand. If you can find it or pick it or grab it off the dining room table, bring the mushrooms in if possible. If you see chunks of it in the vomit, bring the vomit in for us so that we can try to see if these poor mycologists can find it, and then treat them symptomatically and supportively, just like you would any other patient that you have there. And then just relate the story so that way we can work together as a group and figure out if the mushroom needs to be a big piece of the resuscitation or if it's something that we can ignore temporarily in favor of something else.
So now we move on to the other part, which, I'm not going to lie, I enjoy the Grateful Dead. I'm not a stranger to these sorts of things. Tell us about psilocybin. What's the deal?
So psilocybin is one of the predominant molecules that we find in certain species of magic mushrooms in general. Psilocybin is obviously the hallucinogenic compound, and it works on various receptors in your brain. Like it's going to work on serotonin, it's going to work on dopamine, it's going to work on norepi, it's going to work on a lot of different receptors across the spectrum. And fascinatingly, it'll produce those kinds of euphoric and hallucinogenic effects to the mushroom in general. The symptoms tend to last 8 to 12 hours. And so most people that take them will experience something for quite a long time. And so especially if you're picking up these patients in the field and they're not very deep into their trip, so to speak, that's something to consider when you're thinking about, is this a patient good for a refusal here with sober, safe people, or do I need to transfer them to the hospital? And so it's something to consider when you're looking at these folks. And then because it will affect serotonin receptors, it's important to ask them a medical history in terms of what medications they take and try to identify if they take any other serotonergic medications, SSRIs being the most common among them. Now, in general, serotonin syndrome related to magic mushrooms is very rare overall. It's very uncommon for all the huge number of people that take these things. You would expect to see more cases of this if it was really a big cause of it. And so if you're just taking the magic mushrooms without any serotonergic medication, I would have a low suspicion that that would be your cause of serotonin syndrome if you suspected it. But in somebody that takes many serotonergic medications, it's possible to get yourself there. But again, I think you would have to take either a lot of the serotonergic med or a lot of the magic mushrooms itself. And so these mushrooms can cause some problems, but a lot of them are similar to what you guys have experienced with other drugs, like, people that are having an uncomfortable experience who may be anxious or agitated or confused because of the substance. And you need to treat them supportively from that perspective.
So it sounds like overall, magic mushrooms, fairly benign. They're going to cause some hallucinogenic effects. But where you got to worry is maybe some of these serotonin toxic type effects. If you combine them with like a SSRI or other serotonergic medications, you can get essentially a serotonin syndrome, which actually you came on the podcast and talked about a serotonin syndrome. That's episode 37 if you want to go back and check that out. But that's the big thing we're looking out for and we're worrying about with these magic mushrooms.
That's right. For the most part, if you were to encounter somebody on magic mushrooms, like you're going to probably tell that they are altered in some capacity. if they are calm, they're probably going to have normal vital signs. Magic mushrooms don't often cause big swings in your vital signs unless you're tiptoeing into something like serotonin syndrome. And you might see some mydriasis to come along with it, but it's really going to be their mentation and sort of their history that's going to clue you into it overall. Some people, if they get very anxious with it overall, then obviously you might see some tachycardia and some hypertension associated with it. And that's when people might get hurt in other ways. So people that become very anxious or agitated, they might put themselves in positions where they can get hurt, like they might try to flee from people or they might get into an accident. And so trauma in general is going to be the main way that people on magic mushrooms get hurt at all, because just as you were saying, Ross, the serotonin syndrome worries are pretty low with magic mushrooms in general. It absolutely can happen, but it is something that is very uncommon with them, even with people on serotonergic. So it's something I would think about, and especially if you're noticing these vital sign changes and they're becoming hyperthermic, I would definitely put it to the top of your radar. But I would say when you see these people, I would consider that maybe they're having sort of the quote bad trip and they are tachycardic and hypertensive secondary to that. And maybe a little benzodiazepine might smooth things over for that patient. You might see those vital signs slowly come back to normal.
I guess the nice thing about both, right, is you're going to treat them similarly. Like if they're just anxious from a bad trip, a little bit of benzodiazepine is going to calm them down. If they're having serotonin toxicity and they're hyperthermic, hypertensive, tachycardic, benzodiazepines are going to be your treatment. And essentially, if you're not making headway with the benzos, you give more benzos until you start seeing headway and making headway.
I think you have summed up my 2-year fellowship in toxicology in its entirety with that last statement, Ross. Perfect.
Sure.
I couldn't have said it better.
Great.
What do you have going on? Give benzos.
Give benzos.
That's right.
So
That's right.
Let's say we're not worried about serotonin toxicity. If we are, we're going to go refer to episode 37, figure out how to recognize, treat that. But say it's just magic mushrooms. They're tripping. How are we going to want to approach and treat these patients?
Yeah, and so I think depending on what your system allows and how your protocols work, of course, always work within your department's protocols. But, if this is a patient that is otherwise vitally normal, is not terribly agitated, is with friends and family that are sober and responsible, I think these are excellent candidates to see and do a good history and physical, and then hopefully be able to discharge into the care of those friends and family there and be able to leave them on scene if the patient is otherwise comfortable. Because with that history, again, most people are going to do just fine. And the only thing we're going to do for them in the emergency department for the most part is, give them some benzodiazepines, provide them with a low stimulus environment where they can relax, and then discharge them when they're more sober from that capacity. Of course, if there's any complicating factors that you're worried about, of course, stress can change things. So if, somebody has a bad cardiac history and now they're having chest pain and they're hypertensive, tachycardic, and very anxious from their trip at the same time, yeah, that's a great candidate to bring to the emergency department. Make sure that, we can get a cardiac workup done on them while they're sort of in this hyperadrenergic state overall. But I would say for the most part, this is an intoxication that is going to last quite a long time. And if they're otherwise fine and have sober and safe friends and family that can care for them, I think they're a great patient to leave at home. If there's any complicating factors, I think this is a patient that you bring to the emergency department so we can lay eyes on them. Because again, just like any other process, if you have to give yourself epinephrine for your anaphylaxis, that can cause a heart attack. If you're hyperadrenergic because you're so worked up from a bad trip, that can cause a heart attack. So always keep in mind that other things could be going on, but for the most part, I think if they're safe, you can leave them there. And if you're worried at all, bring them to us.
Yeah, and I think the important thing there that you kind of briefly mentioned was if you have to bring them in, if there's not a sober party or they presented by themselves or sober parties on scene aren't comfortable keeping them, is you want to decrease the stimuli, right? That's causing hallucinogenic effects from the overstimulation is what's causing that bad trip. So what you want to do is turn off the lights, make a very calm environment, decrease the stimulation, and oftentimes that'll chill them out.
Yeah, one thing I was going to throw in, when I was a paramedic in Denver, we would cover a large electronic dance music festival, which is actually, there's a case in episode 37 from 1 year of that festival. And so having been a medic that has seen a lot of these intoxications and then also have some of these conversations with like medical control regarding these patients, I think you also have to maintain a high index of suspicion for co-ingestants. And I think it's worth mentioning, we're talking about, I guess, uncomplicated psilocybin ingestion, but also keep in mind in a concert or party environment, if these people are saying they took psilocybin, but they don't know where it came from, they don't really know the person that gave it to them, or the story is really flaky, just remember people mix other PCP, LSD, they mix these things with psilocybin, they mix fentanyl with psilocybin. Obviously, once we start talking about opiates, we're getting into different toxidromes. But maintaining a high index of suspicion, I think, is really important.
Yeah, I think that's very well said.
It goes along with all these mushrooms, right? As we started out this conversation, if you have a child who had an explorative ingestion of a random mushroom in the yard, you got to take that seriously. That could actually make that child very sick, cause liver failure. And so even though it seems like a very benign, unusual thing, you got to take it seriously. Talk to your local poison center or bring that patient to the emergency department. Nick, thanks so much for coming on. Like bring it home for us. As EMS providers on the ambulance, most important things to do to recognize this, treat it, and help the emergency department diagnose it.
Yeah, absolutely, Ross. So I think just like we were closing on, have that high index of suspicion when you see something that seems like it could be a mushroom. If it's proximal to the ingestion and you have charcoal on the rig and they can drink it, give the charcoal to the patient, because the earlier we get it in them, the better. If you can find a sample of the mushroom in any form, bring it to the emergency department with you, because they can be so challenging to identify that even we need to reach out to people that only do this in the field of study, and they can identify it for us. When you see any signs of symptoms, they could be related to that ingestion if a patient is telling you they ate mushrooms that they foraged sometime in the recent past. And foraging is going to be one of the most common things, followed by exploratory ingestions, followed by people who are intentionally trying to take other types of mushrooms. And remember that in hallucinogenic mushrooms, those are rarely going to get people super duper sick, but they sure can lead to other causes and like trauma or inducing other disease processes in a patient. So make sure you're ruling out other things like that, but rarely they're going to make people super duper sick. So you can sometimes leave those patients in the care of family or friends, or bring them to the emergency department if you're concerned. And as always, it's just been an absolute pleasure being on the show.
Thanks, Nick.
Thanks. Appreciate you, Nick. Again, if you're new to the show, we're so glad you found us. Tell your friends. We appreciate all the support and love you can give us. Check out all of our episodes on different topics in the field of pre-hospital and emergency medicine. Follow us on Instagram. You'll know when new episodes are dropping, and we drop some little pearls of wisdom here and there in Instagram. Subscribe. It does help us. We drop episodes twice a month, and your subscription does help us as we try to grow our show. So thank you guys. We do this for you to try to give you the best possible information you can have to make good decisions out on the streets.